Hi, everybody. Welcome back to our lecture on Individual Module 5.1, and this is Lecture 2. We're going to continue with antepartum, and we're going to be talking about obstetrical history, assessment, and testing. So, moving into my world. Here are your learning outcomes. Now, before we ever get started here, we got to talk about some key terms that are related to childbearing. And here they are listed for you. So pay close attention. I'm going to go over each one of them. Abortion. Abortion is the loss of a fetus before the pregnancy is viable. So there's another term for abortion, also called miscarriage if it happens naturally. Gestation. This is the period of intrauterine development from conception through birth. Essentially, gestation is the pregnancy. Gravida. Gravida is any pregnancy regardless of duration. Okay? So it doesn't matter if you are 2 weeks pregnant or if you are 40 weeks pregnant, it counts as a gravida. Prima gravida. This is a first-time pregnant woman. Multigravida. This is a lady who has been pregnant more than once. Nulla gravida is a lady who has never been pregnant. Para is a woman who has had children who reached a viable age. A prima para, a first-time pregnancy delivered at a point of viability, whether or not that fetus is living. A nulla para, is a person who has never delivered a pregnancy to the point of viability. Now, the point of viability is 20 weeks. That is the reference point we use when talking about viability. Okay? So, prima gravida, again, is a lady who's been pregnant for the first time. Multigravida is somebody who's had more than one pregnancy. Excuse me. Nulla gravida, never been pregnant. Para, the woman who has had children who reached a viable age. Okay, so that means that it's a lady who has had a baby greater than 20 weeks. Does not matter whether that baby was born alive or not, the para still counts. I just kind of wanted to make that clear. Here are some other key terms related to childbearing. Term gestation and pregnancy, that means it reached 40 weeks. Preterm or premature labor, it's happening before it's supposed to, okay? Post-term labor or post-date, that means later than 40 weeks. Stillbirth means the baby is born dead at a point of viability. Antepartum is the period around prior to labor. Okay, so from conception until labor actually starts. That's your antepartum period. Intrapartum is actually the labor and delivery process. And then postpartum actually begins after the 4th stage of labor and then for the next 6 weeks. Now, the 4th stage of labor is your recovery period. So you've actually had the baby, you've had the placenta, and this is the period in which the nurse is rubbing your fundus for that first kind of hour. Okay, EDC, or your EDD, is your expected date of delivery or confinement. So back in the day, once you had a baby, you confined yourself to home. You didn't go anywhere, and that's where that term confinement comes from. But your EDC and your EDD is actually your date of delivery. That's your due date. LMP is your last menstrual period, the first day of your last menstrual period, which, remember back, that is day 1 of your cycle. Now, what's the difference between an abortion, a miscarriage, and a stillborn? So an abortion can happen surgically, or an abortion can happen naturally. All right, we use the term abortion and miscarriage sort of interchangeably. It happens before 20 weeks. If a baby reaches 20 weeks, remember that's the point of viability. After that point, if the baby dies and is born dead, then it's a stillborn. All right, now pay close attention because I cannot write this on the board so that you can see. So take notes. How do you calculate the EDC from Nagel's rule? Nagel's rule is a way to come up with a due date based on the date of your last menstrual period. So here is how you figure it out. You have to have the first date of your last menstrual cycle. You subtract 3 months from that date, and then you add 7 days, and that will give you your estimated or expected date of confinement, or your EDC. So here's an example. If the first day of our last menstrual cycle, our LMP, is March 12th of 2016, or well, let's say 17, okay? March 12th of 2017. We have to subtract 3 months from that. That gives us December 12th of 2016. Excuse me, 2017. And then let's add 7 days. So now we have December 19th of 2017. Okay, I hope that makes sense. March 12th is our LNP. We take away 3 months, giving us December the 12th. And then we add 7 days, giving us December the 19th, 2017. So how do we document obstetrical history? Here are all these terms that we just learned about. This is an assessment of the TPLM system, and this is a general obstetrical history assessment. So this is why you have to know what these terms mean. All right, we have gravida, term, preterm, abortion, living children, and multiple births. So let's describe a mom who is pregnant for the second time. She has one living child who just delivered twins, and she just delivered twins. That's a term gestation. So we have a mom who is pregnant for the second time. So that means she is a gravida 2. She's just delivered twins that are term gestation. So term is, excuse me, so term is going to be 1. Now, we're going to say that the one living child she has is preterm. And now that's not in this question, so take note of that. All right, so we're going to say the living child she has is preterm, which gives us 1 for preterm. There is no mention of any abortions or miscarriages, so A, or abortion, is 0. And she has 3 living children, right? The living child who was preterm and the delivered twins. And then multiple births. She has a 1 multiple birth because she just had twins. Okay, so this would be a G2, T1, P1, A0, L3, M1. Moving on. All right, so with antepartum women, we got to do a reproductive assessment. We have to have a complete physical examination with an obstetrical history, which is what we just did. We want to know medical and surgical history. We need vital signs because we want a baseline. We need weight and height because we want a baseline for those as well, specifically weight. We want to see if we can actually hear a fetal heart rate. We can hear a fetal heart rate with a Doppler around 8 to 12 weeks. And normally, sometime between 8 and 12 weeks is when a lady will come in for her very first prenatal visit. So you can usually hear the fetal heart rate with a Doppler at that time. We need to do a pelvic examination, internal and external, plus a rectal exam. Some doctors will defer the rectal exam. This is done by the physician. This is not done by the nurse, just so that you know, because they take pelvic measurements and they determine whether or not the pregnancy can actually be delivered through the pelvis. Does the pelvis lend itself in a way physically that will allow a baby's head to pass through? So that's why we take pelvimetry measurements. We also do a uterine assessment. We do psychological assessments. We learn about the lady's lifestyle, her social support system, her family assessment. All of those things are important whenever you're talking about someone prenatally in the antepartum period. And we also want to do a cultural assessment because that will have a huge impact on how she treats her pregnancy and how the labor and delivery is going to go. Now, McDonald's method is part of the uterine assessment. And what it does is it measures the size of the uterus to assess fetal growth. And it roughly corresponds to the gestational age of the fetus once we hit somewhere between 16 and 36 weeks. So at 16 weeks, the baby should be 16 centimeters above the pubic symphysis. Somewhere around 20 weeks, the baby should be at the umbilicus. And then you can sort of look at this picture to kind of determine how you would assess the uterus. And so the way that you do this, the way the physicians do this and the nurses do this, is you actually feel the top of the lady's uterus or the fundus. And wherever that fundus resides at in the abdomen gives you a general idea of what the gestational age is. And we can track that progressively with each prenatal appointment and determine whether or not the baby is growing appropriately in utero. And there is actually a little measuring tape that you can put on the bottom of the top of the pubic symphysis. We'll stretch that measuring tape out and determine how many centimeters exactly the fundus is. All pregnant women get laboratory and diagnostic testing. To determine that she's pregnant in the first place, we do a pregnancy test. She can do these at home. These can be done at the office. It can be done with urine or with blood. So usually if we're doing a urine test, we want the first morning urine. It has, the first morning urine will have the highest concentration of the pregnancy hormone, HCG. And that's what we're looking for to determine that positive pregnancy test. There are also urine immunoassay tests also. They become positive within about 10 to 14 days after the first missed menstrual cycle. You don't have to know a lot about that, just kind of wanted you to know that term. Many people do these pregnancy tests just over the counter. There are test kits. You can buy them for $1 at the dollar store for the most part, and test at home. Whenever you call the doctor's office to make an appointment, they usually want you to have a serum blood test because there can be false positives, and some women may not know how to read these accurately, or they may not get the first morning urine, and they may just not be accurate. So many doctor's offices will require you to have the blood test done prior to your first appointment. These are the routine laboratory tests that every pregnant woman gets prenatally. These are prenatal labs we draw on everybody. We draw a CBC, a type, and an RH. We draw a rubella titer. Remember that we want, hopefully, the mom to be immune to rubella. MMR is one of those vaccines they cannot receive if they're pregnant because it is a live vaccine. And we're looking for whether or not they're immune to this when we draw this, because it can cause severe congenital anomalies if the mom contracts rubella while she's pregnant. So we look at this in a ratio way. If it's 1 to 10, then the greater than a 1 to 10 ratio, then the mom has normal immunity. If the ratio is less than 1 to 10, the mom is susceptible, and then she'll need the vaccine after she delivers. VDRL and RPR is short for Venereal Disease Research Lab and Rapid Plasma Reagent, and that's the test for syphilis. We do urinalysis to determine if there are any kind of infections or if there's glucose. A small amount of glucose may be normal. We also offer a maternal serum alpha fetal protein testing, or you will hear it called a maternal ASP. And this detects fetal abnormalities, specifically neural tube defects, but it's not a diagnostic test. It only indicates the need to test further. This is a test that actually has to be paid for. So this is one that obstetricians will offer to do at around 20 weeks, but the mom has a choice as to whether or not to do this. It's not something everybody has to do, only if they want. Hepatitis B, we test for that. We always do HIV screenings. Some places do a TB screening. Vaginal smears are always done. We get chlamydia and gonorrhea cultures, and we look for other sexually transmitted infections. And then sometime around 35 to 37 weeks in the antepartum period, we will do a group beta strep smear to test for the presence of group beta strep in the mom. This smear is collected from the vaginal canal and from the rectum. There's some other screening and diagnostic testing that can also be done in the antepartum period. We have ultrasounds. Everybody is familiar with those. In pregnancy, we use those to actually confirm the pregnancy. We use them to determine placental location, gestational age, normal fetal growth, fetal abnormalities, and to determine the presentation of the fetus, meaning which way is it turned. Fetoscopy also can detect anomalies. Amniocentesis will detect anomalies in lung maturity. Amniocentesis is when they actually take a sample of amniotic fluid and test it, and they do that with a needle. It's a sterile procedure, and it has to be also ultrasound guided. Nuclear translucency testing detects anomalies. Chorionic villi sampling also detects anomalies. In the picture, you can see amniocentesis and chorionic villi sampling. Chorionic villi sampling is actually where they use a speculum, they insert it into the vaginal canal, and they use a catheter. They insert it into the uterus, and they actually take a sample from the chorionic villi of the placenta and test that. A biophysical profile is done to determine and assess the fetal status in utero, and we do that using an ultrasound. Non-stress tests and contraction stress tests are also used to determine and assess fetal status as well. So let's move forward. Here's some other diagnostic tests. Fetal activity monitoring, that just means that we're looking at the fetal heart rate in relation to the uterine activity and reading those. Ultrasounds, again, transvaginal or transabdominal. This looks like a repeat of some of the tests that we've already talked about. The first trimester combined screening also is done to detect anomalies if need be. Skip down to vibroacoustic test. This is a test that we do to also determine and assess the fetal status. We'll talk about these in depth as we progress. Ultrasounds. So there are all kinds of indications for using an ultrasound. We can validate that the lady is actually pregnant somewhere between 6 to 8 and see the fetal heart rate somewhere between 6 to 8 weeks. So that's when the heart actually starts to beat, and we can determine viability of the pregnancy with an ultrasound. We can look to see how many babies are in there. We can look at the size, the position, and the presentation of the baby. We can identify structural anomalies, so we can see if the baby has gastroschisis or some type of neural tube defect. We can actually do echocardiography this way on the fetus. We measure growth and structures. We can also determine how much amniotic fluid is inside the placenta with an ultrasound. We can look at the location of the placenta to make sure it's in a safe place in the uterus. We can see actually even sometimes how well the placenta works, so we can identify if there's any calcified spots. We can use it in conjunction with other procedures to help determine fetal wellness, such as amniocentesis. And it will also help us determine if there's any type of fetal demise as well, because you can see that the heart has stopped beating. Non-stress test. This is something that's used very frequently in the antepartum period. It identifies fetal heart rate responses due to fetal activity. So think about yourself. As you exercise, what happens to your cardiovascular system? It increases its need. Your body increases the need for more oxygen, more blood. As you exercise, your heart rate increases. Well, the same thing happens in utero. As a baby moves inside, their heart rate should increase. We can do this between 30 and 32 weeks, and then on through the remainder of the pregnancy. We use an external fetal monitor, and you can see in the picture this lady has 2 little discs on her abdomen. One of them is a tachometer, which determines pressure of the uterus, and the other one is actually an ultrasound that will transmit fetal heart rate. So for the non-stress test, we're actually using the fetal heart rate ultrasound. So we use the external monitor. We need at least 20 minutes of fetal heart rate strip to determine a result for the non-stress test. We have to look at that and interpret it, and here are the different things that we can get. If the non-stress test is reactive, then we have 2 accelerations that are at least 15 beats, above the baseline of the baby's baseline heart rate, and those 15 beats above the baseline lasts for at least 15 seconds. Okay, so it's kind of hard to explain that on here. I'll actually have to show you an example of that, but look for the example in your book. Okay, so for it to be reactive, we have to have 2 accelerations in the heart rate, and they have to be at least 15 beats above the baseline heart rate, and they have to last for at least 15 seconds. Okay? If it's non-reactive, we do not have that. And if it's unsatisfactory, then we just need to look at it further. So it might be that we did not have 20 minutes worth of strip. It might be that the baby didn't move for those 20 minutes. During the non-stress test, one thing that we do is we give the mom a clicker. And when she feels the baby move, she presses the clicker, and it will show up, a little mark will show up on the fetal heart rate strip at that point. So we know when the baby's moved, and we can identify whether or not the accelerations happen in response to that movement. Okay, so here is an example, actually. I didn't know I had this on here. So if you look at this fetal heart rate strip, we're looking at the top section. Don't worry about the bottom. Don't worry about the bottom graph. Only look at the top graph. You see where we have these big jumps in this squiggly line. That squiggly line is the baby's heart rate. You can see that it's mostly for this strip in one general area. And I don't know if you can see or not, but it's around 150 beats a minute. There are 3 places on here where that heart rate spikes. Each of these little blocks counts as 10. So if the baby's heart rate goes up at least 15 beats above baseline, and it stays there for at least 15 seconds, then we can count that as an acceleration. And we need 2 of those in 20 minutes to say that a non-stress test is reactive. Okay? So here we have 3. They do increase at least 15 beats above 150, and they do last at least 15 seconds. So this particular non-stress test would be considered a reactive one. That means the baby reacts to movement. That's a good sign. This is a non-reactive, non-stress test, or this could be unsatisfactory. All right, so again, we're looking at the top graph. You can see that there is a steady sort of baseline heart rate but we have no spikes in the heart rate. We only have dips in the heart rate. Okay? So we have no accelerations, which means if we had 20 minutes worth of strip here, we would call this non-reactive. Now let's say we only have what we see on the screen right now. That's each dark line counts as a minute, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have about 10 minutes worth of strip. And if that's all we had, we could call this unsatisfactory because we don't have 20 minutes to look at. I hope this makes sense to you guys. I know that it is all brand new. Vibroacoustic stimulation. This little device that you see here is a little buzzer. And you actually hold it, there's a button on it, and if you press it to the abdomen, it will create a vibration and a buzzing sound. And what we do is we use this to artificially induce movement. So if the baby is not moving, if we are looking at performing a non-stress test and we cannot get the baby to move, we can use this vibroacoustic stimulation to help induce movement. The baby doesn't particularly like that vibration and doesn't particularly like that buzzing sound. So if you put it on the abdomen for 2 to 5 seconds, we can do it at 1 minute intervals, and we can do it at least 3 times. Then hopefully it will help the baby move, and we can determine a response in relation to the non-stress test. Biophysical profile. This is done with an ultrasound machine. We do this, and this is ordered by the physician if there's some type of suspected fetal compromise. So we might feel like the baby is not doing quite as well, or we can use it as a monitoring tool for people who have very high-risk pregnancies. We look for 5 variables, and each one gives you a maximum of 2 points. We look for breathing, and yes, the fetuses do attempt to breathe in utero. They make breathing movements, so you can see their chest expand just like you would if you were counting respirations for an adult. So we look at breathing. We look at gross movement of the body and the limbs. We look at fetal tone, and remember how we like to see babies positioned. We like them to be nice and flexed. If they are not flexed, something is not right. So we look at fetal tone. We look at the amount of amniotic fluid, and then you do also a reactive, hopefully they have a reactive non-stress test. So we can also add in the non-stress test to help with this biophysical profile. So we have to score and interpret this. A score of 8 to 10 is normal, and something below 7 is abnormal. Contraction stress test. Now, when you're studying these, be very careful not to mix up contraction stress test and non-stress test. Our non-stress test is in relationship to fetal activity. Contraction stress test is what the baby's response is in relation to contractions of the uterus. Okay, so the relationship of the fetal heart rate to contractions, and they can be spontaneous contractions, or we can induce those contractions. What we're looking at is the baby's response or the baby's tolerance to labor. If we do this test and the baby does not tolerate contractions well, then we know that this baby probably will not do very well during a normal vaginal delivery, right? Because that baby has to go through a whole lot of contractions to actually be delivered. So if you have a poor contraction stress test, it might help the doctor determine that this baby may need a C-section. In the absence of a contraction, we can actually induce this test by using IV oxytocin. You can use nipple stimulation, or and you can do that through a breast pump, so breast pump stimulation. Now, rarely ever do we use nipple or breast pump stimulation. We normally always use intravenous oxytocin to stimulate contractions. We have to have at least 3 contractions, and they have to last at least 40 to 60 seconds for us to actually count that contraction as one of our contractions. Now, here's how we interpret that. The contraction stress test can be negative, positive, equivocal, or unsatisfactory. If it is negative, then we have had 3 contractions that have lasted the appropriate amount of time, 40 to 60 seconds, for at least 10 minutes, and we have had no late decelerations. Now, decelerations means a deceleration in the heart rate. So if we have a baseline heart rate, we want to make sure that the baby's heart rate did not dip below the baseline after the contraction. And this is a good sign because it means that the fetus has an oxygen reserve if we have a negative contraction stress test. So think about that for a minute. If our uterus contracts, then we are essentially compromising circulation to the baby. Okay, baby gets its circulation from the placenta. If we contract the uterus and we slow down that blood supply getting to the baby, then the baby does not get the needed oxygen from mom. Babies build up an oxygen reserve in utero. If the baby uses up all that oxygen reserve, or they don't have an oxygen reserve, and they go through a stressful period like a contraction where we cut off blood supply, it would be just like you holding your breath underwater, okay, or holding your breath, period. If you hold your breath for a long enough period of time and you don't have oxygen flowing through, eventually your heart rate will slow down. The same thing happens to a baby. Okay, we do not want to see that heart rate slow down. So if the contraction stress test is negative, that means we had no slow down periods or no late decelerations in the heart rate related to those contractions, and it means the baby has an oxygen reserve. If the contraction stress test is positive, that is a bad sign. It is not good. Positive means that we had persistent and repetitive late decelerations with more than 50% of the contractions, okay? So if we have a 10-minute period where we have induced 4 contractions and the baby had a late deceleration with 2 of those or 3 of those, then we would call it a positive contraction stress test. That means the baby is not going to tolerate labor well. UPI on the screen means uteroplacental insufficiency. That means the uterus and the placenta are insufficient to carry that baby through a stressful period. Equivocal means that the result is suspicious and we need to do more testing. So maybe we have 10 minutes of fetal heart rate strip, maybe we have 5 contractions, and maybe 2 of them have a late deceleration. That's not quite 50%, so we can't call it positive, but it's equivocal, right? It's we just aren't quite sure. It doesn't look good, okay? Unsatisfactory means that you just don't have a good enough tracing to make a determination. So we might not have been able to get 3 good contractions in a 10-minute period. Maybe we weren't able to pick up the fetal heart rate accurately because of the mom's size or because of the way the baby was positioned, okay? So that would be an unsatisfactory test. It means you can't determine any way whether it's negative, positive, or equivocal. There are some complications associated with contraction stress testing, especially if you are inducing those contractions, because there's a possibility the patient could go into preterm labor. Or we could hyperstimulate the uterus, meaning that we could set it into a period where it contracted too much for too long, and that can cause complications for the fetus and the mom. So let's look at this example. This is a negative contraction stress test. Now, remember what we said about negative. Negative is good. Okay, the bottom part of this graph are contractions. So all of those little things that look like mountains are contractions. And what we're looking for is 10 minutes of strip. We want to see at least 3 contractions, and we want those contractions to last at least 40 to 60 seconds, okay? Each of the dark blue lines represents a minute. The light blue lines are 10-second blocks, okay? So you can see that we have, let's try to find one that starts pretty on the money. Okay, so from here to here is 1 minute, okay? Each of these blocks are 10 seconds, okay? So 10, 20, 30, 40, 50, 60. This is where your contraction begins, right here, if we're looking at this particular one. So it starts here, and it's over here, okay? So we know that it's lasted this entire time. That's 60 seconds plus 70 plus 80. So this contraction is 80 seconds long. That's how we determine the length of a contraction or the duration of a contraction, okay? Now, what we're looking for in regards to the fetal heart rate is that we don't have a late deceleration. Now remember, everybody has a baseline heart rate, just like baby, and so does the fetus. So our baseline heart rate is kind of right in here, okay? Right in there. You can see it's about 145, okay? And it kind of fluctuates between 150, 140, so we can call it 145. Now, if we look in relationship to this contraction that we were just talking about, let's just go straight up, and you can see the baby's heart rate does not take a dive, okay? It doesn't dip down like that. That means we have no late deceleration, okay? So there are no late decelerations on this strip, which means we have a negative contraction stress test. That's a good sign. This is a positive contraction stress test. Look at each contraction that you have here, okay? Every single contraction shows a deceleration in the fetal heart rate. if you see this. So look at this contraction, go straight up. The baby's heart rate dips right after the peak of that contraction every single time on this strip. That means the baby has no oxygen reserves. This is the point where we've cut off oxygen the very most to the baby at the peak of each contraction. So if our heart rate decreases after that, it means the baby's not going to do very well in labor. So this is a positive contraction stress test, and this is a bad sign. It represents uteroplacental insufficiency. This is equivocal or suspicious, okay? And you can see that we have a dip in the heart rate here after this particular contraction, but you don't see that again with the other two contractions you can see on the screen. So we cannot call it positive because we don't have these late decelerations repetitively with each contraction. But it's equivocal because this still is not a very good sign. We are suspicious that this baby may not do very well during labor. And here's one that's unsatisfactory. I know these are kind of blurry, but if you can just see in general, there are no contractions here really. There's one. You can see this, that is one contraction. But the rest of this is not either a picking up contractions or the mom is not having contractions. So this is an unsatisfactory test because we cannot make a determination and we cannot interpret the test. Couple of more slides and we're done. Amniocentesis. This is another test that can be done. It can be used diagnostically. This is a sterile aspiration of amniotic fluid, and we use it to analyze that amniotic fluid for certain things. We can look for fetal anomalies, or we can look at how well the lungs are developed, and that's an important thing to remember. We do this under ultrasound, the guide of an ultrasound. And the reason is because we do not want to puncture the placenta or the baby with this needle. We can do this at 16 weeks. And right here it says ultrasound guided to prevent accidental puncture of products of conception. The nurse's responsibility during this procedure is to monitor the vital signs and the fetal heart rate before, during, and after the procedure. We want to know what the vital signs and the fetal heart rate look like prior to beginning this procedure so we have a good baseline. We want to monitor it while the procedure is happening so we can detect any complications, and we want to monitor them afterwards to make sure that the mom or the baby doesn't have any complications after it's over. We look for signs and symptoms of bleeding, preterm labor, infection, and leakage of amniotic fluid after this procedure. If the mom is Rh negative, then she has to receive a RhoGAM injection. Because remember, we talked about the difference between the blood of a fetus and a mother. If the mom has negative type blood and the baby has positive type blood, if those bloods get mixed up, the mom's immune system will make antibodies that will actually attack the baby's blood supply. So we give an injection called RhoGAM to prevent that from happening. So something to note, if we do this amniocentesis sometime between 15 and 20 weeks, we do it to detect anomalies usually. If we do it sometimes between 33 and 40 weeks, we do that to detect lung maturity. And then we analyze the fluid. We can do a quadruple screen, and that we'll look for different types of trisomies. The fetal lung maturity is the big one that you hear talked about with amniocentesis. And remember, I said that's between 33 and 40 weeks. When we look at lung maturity, we look at the lecithin and the sphingomyelin ratio, and those two things are phospholipids and surfactant. The ratio between those two should be 2 to 1. If it's not 2 to 1, then the lungs are not developed appropriately. Baby's lungs have to have surfactant to be able to breathe properly outside of mom. If they do not have this surfactant in their lungs, then they cannot ventilate like they should. So this is why we test that. It would be something that we would do on somebody who is having preterm labor, and we are trying to keep them in the hospital and trying to prevent them from delivering. And it may be somebody who's continually contracting. It could be somebody whose water has broken very early. They've had premature rupture of membranes, and we're keeping them in the hospital to try to get them to a point where the lungs are mature enough for us to safely deliver that mom. So that's why we look at this LS ratio to determine if the baby has enough surfactant to survive. That's really kind of what I want you to know from this slide. You can also see blood, meconium, and fibronectin could be present in this amniotic fluid. Fibronectin is something that we test for that will help us determine the risk for preterm labor. And blood and meconium, if seen in amniotic fluid, are indicative of other types of issues. It should be nice and clear, like what you saw in that vial. So, chorionic villi sampling. Chorionic villi are tiny parts of the placenta that are formed from the fertilized egg. So they have the same genes as the fetus has. And we can detect Down syndrome, cystic fibrosis, sickle cell. We can detect the sex. We can detect muscular dystrophy, the certain type of muscular dystrophy that occurs in males, by using this type of diagnostic testing. It's ultrasound guided. It's done very early, between 10 and 12 weeks. And what we do is we aspirate a small piece of the developing placenta. You can do it through the abdomen or through the transcervically. And then we test that small piece of tissue for chromosomal abnormalities. And we can do metabolic studies and DNA studies. The one thing with this testing is that it cannot diagnose neural tube defects. So that's a negative side. But there are complications that go along with this, and the mom might see bleeding, infection, rupture of her bag of waters, the RH, isoimmunization for RH negative moms. So this is another procedure where the mom would need RhoGAM. And what's the advantage of this particular type of diagnostic test? It can be done very early, so much earlier than an amniocentesis, and it gives mom a safer option to terminate the pregnancy earlier if she chooses so because of abnormal findings. So, for example, if you have a mother who has a family history of genetic abnormalities or chromosomal abnormalities, and she does not want to carry a pregnancy that is not healthy or that has some type of anomaly, this particular testing would give her the option to terminate the pregnancy early if there were to find something wrong. So that sort of ended on a bummer, but that is the completion of individual module 5.1, PowerPoint 1, and this is the end of lecture 2. So we will move forward with the next video recording and talk about some other antepartum things in PowerPoint 2 for individual module 5.1. I know that was a lot of information. I know that a lot of it is very unfamiliar to you. So please study it hard. Try to listen to the different things that I explained. Please come to me with questions. Do not just struggle through this information. I am here to answer questions for you. We will go over examples in class because I know it is all brand new and it is a lot. So don't feel alone. Have a great day. Thank you for listening.